Hi, everybody. Apologize for having to start a little bit late. We've had a really terrific first set of discussions. And now we are into panel number one. I'm Chris Laxton, for those of you who weren't part of the opening session. Without further ado, I want to get you into your discussion. So Robin, I'm going to hand this over to you.
So I'm delighted that you all had such a good first session. We are thrilled to be joining you this afternoon for a panel discussion focusing on racial inequities that are experienced by nursing home residents and their families. The panel has two goals. First, we want to increase your awareness of the actual impact of these disparities on residents and their families, because you have to understand something in order to be able to do something about it. And second, to start exploring some possible solutions that can be translated into action steps. To help us accomplish those goals, we have really a stellar panel for all of you this afternoon that I want to introduce to you. So we're hoping Maurice will join soon, but let me begin with Arletta Brinson. Arletta is a retired executive director of student support services in an urban school system. She holds a PhD in school psychology from Georgia State University and is a proud, that's important part, a proud
yes, that's important.
graduate, right? Of Spelman College.
Yes.
Arletta's mother was both a short-term and a long-term resident at AG Rhodes community, and she has been a volunteer with Rhodes since 2014 when her mother became a resident, and because her engagement and involvement at Rhodes is so important, she actually has continued her involvement there since her mother's transition in 2018. So welcome, Arletta.
Thank you.
We also have Kelly Richards. Kelly has devoted 21 years of her life to public service for the state of Illinois. She's currently the Illinois State Ombudsman and has been in that position for the last year and a half. And then prior to serving as state ombudsman, Kelly was the deputy state ombudsman. Our next panelist is Sarah Slocum, who is co-director of the Alterum program to improve elder care. Sarah has been with Alterum for 4 years, working on various projects to improve nursing home care, expand PACE, and work toward better community-based options. So Sarah really covers the whole continuum of long-term care there. And before Alterum, Sarah was the state long-term care ombudsman in Michigan for 13 years, worked at ARP, and directed Michigan's SHIP program. So Sarah also brings a wide range of experience to us today. Okay, so let's get started with our discussion, and we want to start by hearing the different perspectives on the effects of racial disparities on nursing home residents and their families. And why don't we start with Arletta, since you're, if you had a loved one who was in a nursing home. Just so everybody knows, we all had a discussion last week about this topic. And so that really has helped inform our questions today. So Arletta, when we talked last week, you shared that in the community where your mother lived, AG Rhodes, that leadership and many of the staff, in addition to the residents, are people of color. So I'm wondering if you could tell us how you think that impacts the experience of the residents.
Well, I listened to a portion of the keynote address today, and it was very informative. And it also helped me to reflect upon some of the comments that I gave to you guys last week. And one of the issues at AG Roads is evidently it's somewhat of a jewel, in as much as the composition of the staff at AG Road was predominantly people of color, but it was also some diversity there. And when I think about the staff at Rhodes, it really says that representation matters.
Mhm.
And you could really see representation in action at AG Rhodes, Atlanta. When my mother was first admitted, the director was a Black man, and it mattered that he was in a position of power, not just a position to check off a box.
Mhm.
And ultimately, he went on and is now the chief executive officer for the group, the Rhodes Nursing Home Group. The assistant director was a white female. The nursing director was a male from New York named Baha. And until this panel, I had not thought about what his ethnicity was, probably Lebanese. The female, African-American female director of finance was a local Atlanta person. The leads on music and horticulture were white males, while the director of rehab services was a Black female. The admission staff was primarily young, vibrant people of color, and the receptionist was a pleasant, seasoned individual who brought a sense of peace to us overwhelmed family members. So this resident facility, as you can see, challenged all the racial, age, and gender stereotypes about who was in charge. And I think that made a really big difference in terms of the culture of the organization. Now, the CNA workers, like many in the health sector, were primarily people of color whose origins were literally all over the world. Many were immigrants. And despite what we knew as family members about their having relatively low wages, they were above industry standard in our local area, but they were still low wages. And we know that that's based on what this conference is really talking about, a lot of the structural, economic, and racial disparities. But despite that, these were some of the most dedicated people. They provided personal and personable services to us as family members. Of course, the ultimate connection at Rhodes was the fact that the activities director was a Spelmanite. And so that helped my mom to settle in, and me as well. But it didn't matter that my mother was a Spelmanite. It mattered that she was a person and a resident. And so she just got really great care. The diversity of the staff helped because the residents were very clear that their voice was heard. And if it wasn't heard, these were some really forceful advocates for themselves. They were going to make their voices heard. Now, that resident council at AG Rhodes was a force to be reckoned with. And I guess, again, in terms of just the culture of that particular center, because it was diverse, they were willing to listen from a family's perspective. Were there problems? Yes. Were many of the problems rooted in the problems that, this conference is dealing with? Certainly. Our biggest concern, our biggest complaint was understaffed. Even though Rhodes staffed at a patient to service provider level greater than what was required, as a service recipient, we just didn't have enough. And again, that was issues that were beyond the control of that particular institution. So we were blessed, but of course we could see where the challenges were. And there was continuous, improvement. And sometimes now, they did plot the revolution between the residents and the CNAs, but the leadership tried to be very responsive.
I think we'll sort of hear from different people and then circle back around depending what our time is, because we certainly would love to hear more from Arletta. Kelly, as a state ombudsman and as a deputy state ombudsman, I know that you've been in and out of facilities a lot, many facilities in the course of your work. When we talked last week, you talked about you mentioned that, in fact, you described like segregated homes. That was the word you used, segregated nursing homes in Chicago, where you observed inequalities in the quality of care. And I'm just wondering if you could share with us a few examples of those inequalities that you saw.
Sure, Robin, thank you. I'll be happy to elaborate. So one of the most important determinants of quality in long-term care facilities is the level of staffing. And in Chicago is a very segregated city. You have the majority of African Americans living on the south and the west side of the city. So as a result, you end up finding that nursing homes on the south and the west side of the city tend to be segregated as well. African Americans and other minorities who are on Medicaid disproportionately reside in poorly maintained long-term care facilities on the south and the west side of the city. We tend to see a drastic distinction in the level of care in these long-term care facilities that house residents that are on Medicaid. These facilities, which typically serve minorities, are offer less care than those of predominantly white communities. And what I mean by that is you tend to see these facilities are generally crowded, have less staff, result in poor quality of care. I've spoken to family members of residents who reside in these facilities, and they generally say that the facility is subpar. And you mentioned I've traveled to not all of them, but facilities across the city and suburbs and throughout the state. But what in me seeing and going inside these facilities, I have witnessed things in terms of people not being able to be responded to because there's not enough staff there. The staffing ratios are different. These facilities tend to be crowded. And when I'm talking about staff, I'm talking more specifically, not just your CNAs and your nurses, I'm including your activity persons, your restorative care, your therapy aides, your social workers, not having enough of those people to serve the residents that are in the facility. And so thus you find that residents aren't being fed when they should, not being repositioned when they need to be repositioned, not having the therapy that they need to move on or to matriculate to another level in their care, and on and on. And what you find in these facilities that have a predominantly white folks, you find better care, you find better staffing, and less opportunities for injury. There's data that shows that racial disparities in the quality of care provided by long-term care facilities is a common occurrence. So I know we're short on time. I'll just leave it right there for you, Robin. Thank you.
Thank you so much, Kelly. That is a very stark comparison and distinction between a tale of two facilities, two very different sets of conditions there. So thank you. I'm delighted to welcome Maurice Miller. Maurice, we're so glad you were able to join. Let me give a brief introduction. Maurice is a nursing home resident. He lives in the Washington, D.C. area. This is the 10th anniversary of the stroke that left Maurice a functional quadriplegic. In January, he's going to start his 9th year of residing in nursing homes, and 8 of those years have been in the nursing home where he currently resides. He describes himself as an ableist. I mean, he fights against ableist, I have to say, and racism. And he refers to ableist as experiences where differently abled individuals are basically prevented from realizing their own personal potential and what they can contribute to the larger society. He also says that he experiences and advocates against racism. He's a journalist, used to cover legal and governmental affairs, and he hopes to get back to journalism, and he wants to cover the long-term care beat. So Maurice, thank you for joining us. And we're in the middle of discussing some of the questions. And I'd just like to start by asking you what it feels like to be a resident in a majority minority nursing home.
Well, thank you, Robin. I think that's a relative question. African Americans, of course, have a large and proud history. We've come by force to a land where we've been subjugated, suppressed, oppressed, and each of us have added to that a long history, and yet we have successfully become equal chemists to the experiment that's in America. And that's a powerful story. And that's something that each of us can affirm positively. And so, to a certain extent, in some nursing homes, that means that there's a great deal to celebrate. And you should be able to have a lot to affirm. Your light should be able to continue to shine, and the lights around you should be able to continue to shine. Unfortunately, in some nursing homes, including mine, that light diminishes. You come into the nursing home because of circumstances from the outside that have maybe caused you to become tired, and you are looking for hope. You know, your moms or your pops. This is your moms. This is your pops that you're checking into the nursing home. This is the person who's raised you. And raised your grandson and your granddaughter. This is the person that you're checking into the nursing home. So you're looking for hope, and they are looking for hope. And so when they come to the nursing home, even though their light is so much dimmed, there's still a sense of hope that things will be able to get better. And when they come in here and they're not better, either by accident or intentionally, that light gets diminished. And that's significant because a lot of people who are here are people, as I said, who have done great things. They've raised families. They've raised families. Yes, we've had people who are historic, and it's sad when that happens. There was a person here who was a member of the people who was at the Edmund Pettus Bridge, who did not want to get out of bed. And that's a commentary on us when we dim people's lights. And we're not helping. We're not helping. We're darkening people here. And I guess that's what should not happen. Whether it's the facility itself or whether it's we as a community, we cannot have that happen.
So we need to make that light shine.
We have to continue to do so. Well, there's fuel that needs to happen. There we need to be able to fuel those people's lights. You know, it happens in other places, and in a majority minority nursing home, it really should be able to be easier to have it happen. But such is not the case sometimes, because we get together and we are unable to support each other. We're too busy having our lights extinguished ourselves. Before I got to this meeting, I got the bad news that another person was leaving today because they have been pushed to their limit, and their light was going to go out if they did not leave. And this is a staff member, and you know, that made part of my light go out. And when that happens, we all get darker.
That's for sure. Sorry about what happened, what you're experiencing today. Very sorry about that. Let me switch and ask Sarah to tell us a little bit about some of what she's been doing. You know, in your work that you've been doing to improve elder care, one of the things I know you've been focusing on a lot is culture change. So I wondered if you could tell us, just give a brief description of culture change, but also maybe talk about how you think that race and ethnicity come into play in the culture change environment.
Okay, absolutely. Is my audio okay? First
Yes.
time I've spoken, thank you. So Maurice has actually provided a genius lead-in to talking about culture change, because culture change in nursing homes is all about making an environment where the resident's personhood is the primary thing. The person-centered care, where the resident is the center. The residents aren't there to meet some need that the institution has, which would make them widgets, make the nursing home task-oriented, make the most primary important thing getting through the checklist of physical duties that the staff has to do. The residents are there to live their lives because they need support. They are living their lives in that environment to get support, not to be, as Maurice so brilliantly put it, not to have their light extinguished, but to get support. So culture change is really, it was not designed with a racial equity lens particularly in mind, but I think it lends itself well. And I think it works for all kinds of people because it is aimed exactly at that personhood. So culture change, there are a number of different models and curricula and brand names that you might hear related to culture change. But the idea is intentional training, coaching, protocol and practice changes, and really organizational shifts so that the institution, the nursing home, can shift into a vibrant, living, human environment, which all those things are what? Home. So it's not to be an institution, but to provide a home for these residents who need some support in order to live their full lives. How do they do that? They train staff to first of all, communicate with residents, listen to residents. We're working with 6 nursing homes in Michigan right now, mix of urban and rural, mix of populations. One serves predominantly people who were previously homeless and have mental health issues. Another is more in the suburbs and serves mostly white people who have some financial resources. But we see across all of these, the sort of the light bulbs going on. We were having a conversation with the home, the urban home. It has a mix of racial makeup among the residents and the staff, and it has predominantly formerly homeless people. They were thinking about their activities and how do their activities make the residents feel. And you could see through their culture change training that they've had, they started to have the light bulb go off about, oh wait, it's not, yes, we have to meet the state's requirements. And yes, we need some sort of schedule so that it's not chaos, but those things can't drive the daily activities. What has to drive it is just asking, what do the residents want? What are they interested in? What did they do before? What was their line of work if they worked? What were their hobbies? Who are they close to? What are their relationships? So that they can schedule things that are according to what the residents want. And guess what? When they asked the residents did not want extraordinary things. They wanted more chances to spontaneously play cards with a few other residents they had formed friendships with. They wanted certain music. They wanted to have certain little hallway activities because of COVID, that where staff engage with them. They really enjoy that. And Maurice clearly has very strong relationships with the staff. So it's treating everyone like humans, training that specifically teaches institutions how to shift their protocols and practices and their thinking so that they're ready to do that. Of course, they still have to meet all the state standards, and that's never easy, but those really don't preclude, when the right changes are made, they don't preclude meeting people's human needs. And I know we're a little short, so I'll cut this a little short and maybe there'll be some questions, but one of the really key things that we hear from culture change experts as they do this training, and remember, even in homes that serve predominantly white nursing home residents, there's an overrepresentation of low paid women of color in particular. And so one of the phrases that culture change experts really take to heart is how the staff is treated will reflect in how the residents are treated. So it really has to be an entire ecosystem. It has to reflect the cultural needs, desires of the residents who live there, and it has to build relationship. So I'll stop with that, and maybe there'll be a few questions later.
Thank you. That was really well expressed. So thank you. So I don't know, Maurice, if you could see what's going on in the chat, but all our panelists are dynamite. I have to say, you have hit the ball out of the park. People are thanking you for your leadership. They're saying how inspiring what you said is, and they're thanking you for being so open in your sharing. So with my fellow panelists' indulgence here, I'm going to ask Maurice one more question, because I think people are really, Maurice, you're the only one who lives in a nursing home 24 hours a day here. So I think we need to hear from you.
Yes.
When we had this conversation last week, you said something that I think just made all of us just stop in our tracks. And you said that in your nursing home, you've observed what you called the plantation syndrome. Could you tell us what you've observed that makes you say it's the plantation syndrome?
Okay. First of all, I have to have a deep apology to my forebears for using that phrase. But let's discuss it. Plantation, I have to define it as an establishment that makes extreme profits while on the backs, while exploiting those people who basically are totally disenfranchised or disadvantaged, and totally taken advantage of. And we all have a definition of syndrome. It's a set of conditions where people um, suffer a certain type of disease. Um, you know, a plantation syndrome is a situation where people are so conditioned um, to allow themselves to continue under the same set of rules and circumstances that they have no interest in improving their health. They don't know that there's such a thing as a simple thing as HIPAA that allows them to track their diabetes sugars numbers such that they can say, hey, why are my numbers going up? Why, how can I improve them so that they can go down? So that I don't have to take as much insulin, so that the institution does not have to profit so much on my finger sticks, so that I can improve the quality of my life by reducing the risks that I have by becoming worse by my condition. They don't realize that the simple thing that food is medicine, that by improving their diets, they can increase those things. And they don't realize that there are people within their own community that can tell them these things. This month marks 2 years that I'm now insulin free because I have taken the advice of people who have advocated in my behalf. Um, there are um, situations where individuals who try to step up and advocate in behalf of their own selves or on behalf of other residents are considered uppity. And you all know very well what that word is that I did not say. And they suffer emotionally, and sometimes physically, the lashes that are taken into consider that are needed to suppress them, and are even threatened with involuntary discharge to what might possibly be considered worse situations and worse plantations. You are, um, during COVID, you fear the fact that the people, the masters, are exploiting the situation and are celebrating the fact that they are able to keep you under lock and key, and that if all things being equal, they would be able to continue to keep you under control, and they had no interest in opening up the doors and allowing you to meet in small groups. Had CMS not allowed that, and that you fear these things. And the syndrome is so intense that a person like me, the uppity person on the plantation, did not even openly discuss the fact that he was appearing on a national summit on mitigating racism for fear that there might be coincidentally a national, a facility-wide failure in the internet as access among the residents right around the same time he was supposed to go in and log on to this summit this week. Those are the conditions that are in the plantation. You fear for yourself, you fear for your residents, and your residents have no ambition because they're conditioned to think of their lives as being no better. And you don't think of yourselves as having no escape route, no underground railroad. And you don't think of there being any possibility of there being freedom. You don't think that, you don't really believe that there's any emancipation, even though there is in the regulations that exist, because you don't want to pay attention to those. You don't see them and you don't know about them, and you fear even trying to get to them. And you know, I could go on, I guess, but that's it.
Thank, thank you, Maurice. I'm having trouble just even finding words, and somebody put something, in fact, it was Chris Laxton who said, such a powerful and tragic image. And I think that's what I want to say. Your words are compelling and tragic, and they underscore the importance of this summit and the work that we all have to do to destroy that plantation. Let me ask Teresa, I'm trying to get a sense of how much time we have. I do want to say to all of those participating in this panel that we had more questions that we wanted to ask and have our panelists respond to. We had asked them to give us recommendations for ending disparities. So sadly, we don't have the time for that. So I do hope that those of you on the panel, if you have the time, can join the work group tomorrow so you can share firsthand your recommendations. But I guess I would just ask Teresa, do we have time for any questions?
I'll defer to Chris on that. I know the other panels are online and ready to go. But for the question that just came through the chat, how can we be part of a work group tomorrow? That is a fabulous question. Chris, can you answer both of those questions?
I sure can. Thank you, Teresa, and thank you, Robin, and all of the panel today for doing an amazing job in a sadly foreshortened amount of time. What I'm going to suggest is that you send us those questions and suggestions. And if you are able to join a work group on this topic, on the resident and family issue tomorrow, I would encourage you to do that so that we don't lose any of your wisdom. So if you want to be part of a work group, just email me, claxton@paltc.org, and I will make that assignment for you and send you the link. But before I go, I just want to again thank all of the panelists. Maurice, your courage and ability to hang on to hope and keep that light shining is an inspiration to us. Kelly, Aletta, Sarah, terrific presentations from your perspectives. Thank you so much. And Robin, as always, thank you for your engagement and the facilitation today.
Please see the, I'm so sorry, Robin.
Sorry, go ahead.
Please see the chat box for Chris's email address. Oh, I spelled it wrong, didn't I, Chris? PALTC.
That's right.
And the web link for the next panel session. And thank you to everyone for your patience with the timing of the session today.
Very good. We'll move on to the next panel. Thanks, everybody.